Great. So we're really excited to have everyone with us today. We have a number of people online and we have a number of us in person today. So this is our spotlight for public mental health. So basically it's a joint collaboration between Stellenbosch University and us at the University of Cape Town. So I'm Katherine Sorsdahl, the co-director here at UCT, and Assoc does send his apologies for today. What we thought we would do is just give a bit of history of CPMH, because I think we do have a number of new people here in our centre, and sometimes it's just nice to see how far we've come and where we came from. So basically, CPMH grew out of a shared vision and commitment between members of psychiatry here at UCT and colleagues at the psychology department at Stellenbosch University. And the idea to establish a centre for research and training in public mental health at UCT really came from that groundbreaking mental health and poverty project that Crick and Alan Flisher were on years ago. I'm not going to say how many years ago. Meanwhile, at Stellenbosch University, Leslie Swartz, Ashraf Kaji, and Tony Naidu from the psychology department were also in the process of developing a master's in public mental health. And so when this became apparent, it obviously seemed obvious that the two departments should be working together instead of against each other. And that's kind of where this MOU and this establishment of the centre came. So I think it's 2009, there was an MOU between the two universities, and it still continues today with a particular focus on capacity building. So the CPMH was officially named the Alan J Flisher Centre for Public Mental Health in 2011, and Crick was the director all the way till 2017. And then when he stepped down, we decided to restructure the centre a little bit, where Ashraf and I became co-directors with one at each university. And of course, we had a new position for a deputy director, a really needed position that's now held by Associate Professor Claire van der Westhuizen. So that's where we are now in terms of our history. It's now 2024, so I won't give you any indication of the timelines in those pieces. But I think what's really interesting is the objectives of the centre themselves hasn't really changed very much, and I think we do a lot of these objectives in our everyday work. So the first objective is to build capacity in Africa for public mental health policy, planning and legislation through accredited postgraduate teaching programs. And you'll see in this presentations today, we have a significant amount of our time and effort does go into capacity building. To understand high quality research in the areas of public mental health policy, services, legislation, and human rights. You'll notice a lot of our work in the centre is very research focused, and we have a large number of international grants that do this kind of work. We also advocate for the inclusion of mental health in African policy and development agendas, including the mental health policy and strategic plan, and also in other areas of advocacy. And we also do provide a lot of advisory services to both nationally here in South Africa, provincially here in South Africa, and also overseas when asked. So these are the four main things that we do in our centre, and I think we do them quite well. We did become a WHO collaborating centre in 2014, and we are still today, which technically means it's 10 years, so we could celebrate 10 years of being a WHO collaborating centre, which is also quite is a bit of a milestone for us as well. And then to give you a bit of an idea about some of the research projects, and now we're focusing much more on the research projects. This only includes the ones that we're working on now. We did have, Claire and I had made this plan to put them all together in one, but it became so messy that you couldn't see the trees. So we decided to take them out, and perhaps we'll be more creative in the future of how we can do that with past projects and current projects. But as you can see, we have 4 key pillars or 4 key trees. We have social determinants of mental health policy and services, measurement of mental health, intervention, development, adaptation, and implementation. And then these 4 pillars are connected through integration of mental health care into perinatal, infectious, and chronic disease, or any kind of health services. And of course, looking at mental health across the entire lifespan. That all kind of comes together in one. And also just to ensure that we implement robust community engagement, which is really important for any kind of people working in research. You'll see here that we have not only our capacity building, but we also have our youth development team, for example, with the idea of really engaging with the community. And now I'm going to hand over to, we do a lot of task sharing in the centre, so you're going to see a lot of people jumping up and jumping down, to Gillian for the next part. All right, good morning, everybody. Thank you for joining us.
As Katherine mentioned, I'm going to be speaking a little bit more about the centre, but I'm going to be focusing on the UCT side of things. So for those of you who don't know, we are part of the Department of Psychiatry, but our offices are based here at Red Cross in Randebosch. In terms of our staff, as was mentioned before as well, Professor Sorsdahl is our director here at UCT, and her counterpart is Professor Claudia at Stellenbosch, and then Professor van der Westhuizen is our deputy director. So the centre is largely soft-funded, and so we have a core component of staff, and then we employ additional staff as our projects increase and the research demands increase. And so with that, myself and Ms. Songelwa Mobo, we provide the administrative support for the centre for all of the projects. And then we have our operations and IT officer, Mr. Kevin Ernson, and he assists with all the needs once again across the centre. In terms of our teaching component, we offer a PG DIP course, as well as a Master's in Public Mental Health. And Professor van der Westhuizen is our course convener, and our course coordinator is Mrs. Ali. And we're very lucky this year. We've got 6 PhD fellows, full-time fellows with us. Ms. Mkhize and Ms. Ward-Smith are wrapping up their 4th year, very exciting. We have Ms. Moshani, who's busy with her 3rd year. And then we were joined this year by Ms. Joni Mitchell, Ms. Tsebokazi Mtati, and Ms. Cherith Langenwerven-Hierber. In terms of research, we have Drs. Emily Garman and Roxanne Jacobs. They're currently working on our live project. They have a growing team of field workers, so I don't know if you can see all of their names. That box has grown considerably. And then we also have honorary staff. So Professor Crickland was with us. He's actually based at King's College London. And then we have Professor Margie Schneider, and then Drs. Sumaya Dokrak, Rahana Kader, and Carrie Brooks-Sumner. And then finally, to wrap things up, we've got the Perinatal Mental Health Project. They're directed by Professor Simon Honigman, and their study actually focuses on perinatal mental health for perinatal women and postnatal women. And then we actually have some of the team that will be sharing with us about their work as well. And that brings me to the end of my bit. And so I'm going to hand over to Claire. Thank you.
Songelwa. Sorry, Noma. Noma thought I was calling her up early. Okay. So I'm going to hand over to Songelwa just to start us off with our postgraduate programs.
Morning, everyone. My bit is just a little, I only have just one slide to share with you. I've worked with postgraduate program initiated in 2012, as you can see on the screen with the MPhil. So I've worked with CPMH students since 2012 when the MPhil started, and we have a good relationship with our students. I play a vital role in supporting them from the CPMH side. Our programs are the only public mental health degrees and diplomas in Africa. We have had many graduates, including 13 PGDips, 56 MPhils, as well as 10 PhDs. Our students work so hard, so we are very proud of their achievements. Even though many students and graduates are far from Cape Town, they are in contact with us, and it's a pleasure working with them. That's it from my side.
Thanks, Songelwa. So yes, Songelwa knows every single student, I think, that's come through the centre. So I just want to talk quickly about the public mental health training pipeline. So over the years, from the start of the MPhil,
We had the addition of PhD students to the centre, and we've just seen an increased demand for public mental health training. And we realised there's a bit of a gap. A lot of people apply they don't have research experience, they may not meet the academic criteria for a master's, or they may not actually want to conduct research. They may just want to understand it and be able to use the evidence in their own practice. So we realized that there's a gap, that we need to start with a postgraduate diploma where people can understand public mental health, the theory and the research skills, that they can employ critical thinking and evaluate the evidence and decide what can be useful in their context. And then we go on to our masters and our PhDs. And now I'm handing over to two of our fellows. So we've got NomaKhawuta Moshani and Claudia Swinny. Claudia's on the Stellenbosch side. So she wasn't on our slide there. So she's in the Department of Psychology, but we like to claim her as our own.
Good morning, everyone who is here with us physically, and to our listeners at home who are joining us virtually. As Claire said, I am Noma Moshani, and today I will be telling you about the ARISE project. The ARISE project, its aim is to strengthen and to extend the postgraduate pipeline within the African context. So it has 4 different objectives. The first objective is to evaluate and to deliver a remote postgraduate program within the African context. And we also seek to train masters and PhD students in order to provide relevant and contextually, to provide meaningful, yes, that's the word that I was looking for, because that's very important, to provide a meaningful and contextually relevant research that the students can be used in order to address certain problems that they are facing in their context. And as you can see that we also have the other objective 3 and 4, and I will allow you to read those. Cool. All right. So basically, our program is grounded in Africanness, that is being African and proudly African in how we do things, but also to keep on being globally informed. And at the core of that, we are very much aware of social rights and human rights. And also, we are interested in fostering inclusivity as well as diversity. And we are doing that by having multiple people in our research committees, and also different worldviews. Like we embrace having different worldviews, because the people that we work with, they come from different walks of life. And in our faculty, we have people who come from different parts of the world. Some of the people who are advising in the committee, they are from Kenya. We have people from Ghana. We have people from Nigeria as well. And this gives us an opportunity to be open-minded in the things that we do, and to keep in mind of different perspectives and different experiences that people bring to the team. And then in terms of our PGD program, which Claire has really spoken about, this is the caliber or the background of the people that we have. They come from 7 countries, and our new PGD course started last year. So this year we are into our 2nd years. And here we have our 2023 cohort and our 2024 cohort as well. And these people, they come from eclectic backgrounds. Some of them are in correctional services, some of them are sports coaches, some of them school counselors, and some of them in health and religious ministry. That goes to show how important diversity is in the work that we do, to make sure that the programs and the research that we are involved in is cognizant of the unique and contextual challenges that the country is facing and the continent at large. I'll now hand over to my twin, Claudia.
Thank you, Noma. I'm Claudia, and I'm excited to talk to you briefly about the numbers and the students that we have in this brand new PGDIP. So in the In the first 2 years, we had between 30 and 40 applicants. And for the 2025 cohort, we have over 60 applications for this PGDIP. And one of our students in 2023 stepped down because of ill health, but the rest all graduated successfully. And also our current 2023 students, some of them have applied already for masters for next year. So we're very excited about that. So our PGDIP has 4 courses. We start the year with Introduction to Public Mental Health. We give them a good grounding. We move on to research methodology in mental health epidemiology, and intervention and interventions for public mental health. We also include training on other competencies such as research integrity, academic reading and writing, clinical ethics, self-care, other forms of communication such as blog posts, social media, presentation skills, time management and others, which is very important as our students are full-time employed, so time management is a major competency. The course includes a face-to-face orientation block in Cape Town at the start of the academic year, and the rest of the content is delivered online on a course website, with carefully structured content for each week. We use a few other tools for student engagement, such as Padlet, and we enjoy our synchronous online support very much. Our PhD fellows are part of the teaching team and play a vital role in student engagement and support. They're always this happy. We didn't ask them to smile. They're just normally smiling. And I think we encourage that. They're always so enthusiastic in our online classes. And then please allow me to share just a few thoughts from our current 2024 cohort. So this is a quote from Hafsa. She's from the Ministry of Health in Uganda. She's a medical doctor. She said, "This course has enriched my knowledge about the mental health in general and in the research aspect." And then from Sophia, who is a correctional services officer in Namibia, "My critical thinking has changed drastically. I've learned so much and my writing has improved so much." And then lastly, from Bernadine, who is a social worker in South Africa, "It has broadened my understanding of mental health in diverse communities, and it's equipped me with essential knowledge to better address mental health needs in my work." So that's very exciting. Here are a few of our RISE Masters Fellows, and you can see they come from different countries, and we're very excited to have them on board. And then, of course, 2 people that you might be familiar with or recognize. On the left, we have Ms. Moshani. Her topic deals with adapting and testing a brief remote counseling intervention for SADC service users at risk for depression, anxiety, and unhealthy alcohol use. And then, of course, Claudia Swinny, she's exploring referral pathways for common mental disorders in a low socioeconomic setting in South Africa. And this is the ARISE team, many of whom you are familiar with. We are also very fortunate to have dedicated members from the UCT Centre for Innovation and Learning, and that is Nadine Hammond and Andrew Deacon. And then we've recently had a new team member join us, and she's Dr. Emma McKinney. She's working on the PGDIP and the ARISE project, and she's an experienced teacher of children with disabilities, inclusive education lecturer at 3 universities, and disability sensitization trainer and researcher. So we're very happy to have Emma. And I think I've kept to my time, sparing you 1 minute. I'll now pass on to Gillian. Thank you.
Thanks, Claudia. So, yeah, I hope you don't have motion sickness. We're hopping up and down. We like to spread the capacity building opportunities around. And Claudia and I, we practiced epidemiology in times, right? But we can default to epi, so it's fine. I just want to quickly tell you about another capacity building grant. So the African Mental Health Research Initiative, or AMARI, is now in its 2nd funding cycle. It actually started in 2015, and the current AMARI started in 2023. There are a number of different countries, and I think the new countries been added all the time. But in the 2nd version of AMARI, Ghana and Zambia have joined us, so it's really exciting for that. And the project is led by Prof. Dixon Chibanda from Zimbabwe, and in South Africa, well, Katherine is actually the sort of Southern African lead, the hub, and then Songelwa and I run things from UCT side, and then Cherith Langenhoven-Hiba is our PhD fellow. Okay. Just quickly, because we have our Struengmann Initiative Fellows who are going to talk to us now. This is a partnership that was initiated in 2020 between the Andreas and Sue Struengmann Foundation and the Centre for Public Mental Health at UCT. And the purpose is to address the mental health implications of childhood and adolescent adversity and trauma by providing a base for research, capacity building, and policy development. So a big part of this initiative is to ensure the provision of high quality interventions for the prevention and treatment of mental health problems among young kids and adolescents. So we have 2 new PhD fellows every 4 years. Miriam and Chesney are going to be talking to you now. But we've also had 2 new fellows join us this year, Klebokazi and Joni, and they're working with adolescents with PTSD and university students respectively. And the youth development team is also funded through this exciting initiative. And this team is really, I think we say exciting quite a lot, but it is exciting because they are providing input on all our research projects. So it's really lovely to have these young people on board. And now I'm going to hand over to Chesney.
Good morning, everybody. Thank you for being here. So yes, my name is Chesney and I'm a clinical psychologist and a PhD researcher here, hopefully in my 4th and final year, fingers crossed. So I'm going to be presenting my PhD research results, or portion of them, and it's essentially about assessing the feasibility and acceptability of an emotion regulation intervention with physical activity elements for older South African adolescents who are at risk for depression and anxiety. So I want to talk you through the links between emotion regulation, physical activity, and mental well-being in older adolescents. We know from an earlier phase of this research that there are high levels of anxiety and depression symptoms among older adolescents. We know that poor emotion regulation skills are associated with depression and anxiety in adolescents. And that, interestingly, the use of more adaptive emotion regulation skills tends to decline at this age group. In terms of behavior, we know that sedentary behavior tends to increase the risk for these mental health conditions. And on the flip side, increased physical activity is associated with reductions in these mental health symptoms and increases in self-esteem, which we know for adolescents is really, really important. All right. Physical activity is an important active ingredient in mental health interventions for this age group, but in our context, we have very few evidence-based emotion regulation interventions that incorporate physical activity for older adolescents that have actually been adapted and tested. So with this in mind, the objectives for the study were to co-adapt an evidence-based emotion regulation program with physical activity elements for this population from low-income settings who are at risk for depression and anxiety, and then to actually test the feasibility and acceptability of the program. I'm going to give you a snapshot of this co-adaptation process. So the intervention was originally adapted from an existing evidence-based program called affect regulation training. And we then took it and co-adapted it over a kind of 3-phase process with a panel of mental health experts, with our adolescent advisory board, the youth development team, which Claire mentioned, and with 3 groups of adolescents using a human-centered design process. And this all, it wasn't a linear process, it took place, all kind of at the same time, essentially over a few months. Just to talk you through this human-centered design process, so we first needed to discover what was needed and if this intervention was actually necessary for adolescents here. We co-adapted the content and activities. We tested the content and activities in the groups. We refined the content. We integrated the changes and then retested with a new group. So we did this about 3 times with that 3rd group of adolescents. And through this, the hashtag Feel, Think, Move program was born, or FTM for short. I'll give you some examples of changes through this co-adaptation process. So we realized that the program needed to be a little bit more kind of creative and engaging. So we gamified some of the activities and we used the 30 seconds format for one of the recap exercises. And just another example, we used magnetized puzzle pieces as learning nudges for adolescents to take home each week. Some feedback from this phase. So just going to read maybe one quote. So one of them said, it's rare to find places or people that share such knowledge, and having basic skills can help solve big problems. I think it was also turned out to be quite meaningful even in the adaptation phase. We then moved on to actually piloting the program, so testing its feasibility and acceptability. And how did we do this? So this was a quasi-experimental pre-post feasibility study. We collaborated with 8 groups of adolescents from 4 Western Cape schools, and they all participated, they completed a baseline mental health survey, an 8-week follow-up survey, and then a 3-month follow-up survey as well. In terms of training and supervision for this intervention, so we took a task sharing approach. We trained 5 facilitators in total, and this was a mix of registered counselors with a little bit more experience and then social workers who had a little bit less experience, and we paired them up, so 2 facilitators per group, a main and a co. All of the trainers? No, I'm a trainer. The trainees had about 40 hours of training before the intervention start. And they also had weekly debriefing and supervision and extra training as needed. And just to emphasize the importance of quality and consistent supervision over time for an intervention like this. And if you are going to do it, I would also suggest training a backup facilitator in case people leave you and get other jobs. All right. In terms of the intervention details, so it's a group-based program with about 10 participants per group. Initially, it was about 7 weeks long. We've now bumped that up a little bit based on the feedback. It takes place once a week for 2 hours. It's after school and it's at school. In terms of the content, so for me, this is kind of the exciting bit. I'm going to walk you through the content modules, and that's relating to the diagram on the right-hand side. So adolescents learn 5 foundational emotion regulation skills. They learn how to relax their bodies, relax their breathing, become aware of their emotions a little bit more, learn how to accept and tolerate difficult emotions, which in adolescence is quite tricky or can be quite tricky. They learn how to support themselves in this process. We know that self-esteem, like I mentioned, really important for all the adolescents. And then they learn how to investigate the links between their thoughts, their feelings, how it links to different situations, how it links to their actions and what they do, and the consequences of what they do. And that turned out to be really, really crucial, just based on some of the feedback. And then once these foundational skills are grasped, they then learn core emotion regulation strategies. These are all evidence-based. So the first one is distraction, how to actually incorporate more adaptive, healthy activities into their lives. They learn how to problem solve, and they learn how to reframe their thoughts. So you can see there's a kind of a mix of CBT, there's acceptance and commitment therapy, there's compassion and mindfulness-based work. Oops. Okay. Then in terms of the physical activity elements, so we created something called Gym Club, which is essentially a sequence of exercises that gets progressively more challenging as the program continues. And these exercises, they don't require any equipment. They can be done at home. They can be done anywhere. And this is kind of like the foundation of the physical activity. But then we also incorporate other things like dancing-based games and ball skills-based games, depending on, you also have to read the room and see what adolescents want to do. Physical activity is not only used as a means to enhance mental health, but it's also used as a learning vehicle. So just as an example, you might do something like a plank or a burpee, both things that maybe nobody really wants to do. And then you can teach them concepts such as tolerance and acceptance of difficult physical sensations, which can then be a little more easily applied to emotional experiences. And for teenagers, and especially for the boys, we figured that this actually worked a little bit better. Okay. Then in terms of what we actually did, I'm just going to give you a little run through of the study as a whole. So we screened 151 adolescents, 111 met the inclusion criteria, 85 did the baseline survey, 71 completed the whole intervention, and then I'll talk you through the follow-up rates in the next slide. So in terms of the feasibility results, was it actually feasible? Did it work? you can see that a really large proportion of adolescents were actually eligible. So 74%, 77% were successfully recruited, 84% completed the whole program, and our follow-up rates were also quite good. So 99% at the first and 85% at the second. And the facilitator therapeutic competency ratings were also really high, so 96%, and content fidelity, how well they can actually stick to the content, was 86%. In terms of the acceptability results, so was it liked, was it enjoyed by the trainees and the adolescents? So here we use something called the Child Evaluation Inventory to assess the acceptability of the study and the intervention procedures. And we reported the proportion of scores that were 4 or above, so acceptable or highly acceptable. So that's what those results mean there. So just in terms of the total acceptability rating, overall 94% had scores of 4 or more. In terms of the perception of skills learned in the program and the application of skills, about 74 to 76% had scores of 4 or more. Participants also really seemed to like the facilitators, so about 79% had scores of 4 or more. And yeah, just in terms of the overall acceptability of the study and the actual procedures, 84% of participants had scores of 4 or more. To give you a little bit of the qualitative results from this section. So I'll go through maybe the second one. So a 15-year-old female from the study said that the skills that we learned, if I didn't come, I wouldn't have known that. I wish everyone could know all the skills that we learned here, because if you check how many kids that don't know, there's a lot of them. And in terms of the clinical outcomes, so these are secondary, but we saw that there were significant decreases in depression, anxiety, emotion regulation, and PTSD symptom scores at all follow-up time points. And in terms of physical activity and self-esteem, there were significant increases at the first follow-up, and self-esteem remained significantly increased at the second follow-up as well. So in terms of perceived benefits, I'll just run through one of the more expected ones. So one of them was speaking about, their general kind of sense of themselves and their mood after the program. So this is a 17-year-old female. She said, I definitely think we were all much happier afterwards because we learned how to cope with our feelings. We could help people around us. Also, it was physical activity. So that was a bonus because that's good. Personally, I was happier compared to before, and I still am now. We can chat through some of the other benefits, but I don't want to go over time. In terms of the study output, so we have a trainer's manual, which is pretty much ready to go, except for a couple of maybe spelling errors, and then a participant activity book. And they're being finalized, and they will be made open source next year. Okay, so this, in conclusion, the study addresses this gap in context-appropriate emotion regulation programs for at-risk older adolescents, and the intervention is feasible to deliver and acceptable to adolescents. The next kind of logical steps would be an RCT in the next few years, and we are busy implementing the program with one NGO, Students for a Better Future, and another one is in the pipeline with Community Keepers. So a very big thank you to our team and the Sue Struengmann Initiative for funding, supervisors, colleagues, field workers, you're all here. Thank you.
Thank you, Chesney. So our research is quite similar, but my focus for my research is on younger adolescents. And my name is Miriam Kize. I'm a clinical social worker and a research fellow, as I've been introduced. So for today's presentation, I'll also be focusing on my PhD research, and I'll focus on the co-adaptation process and mainly on the testing of the ease intervention with young adolescents and caregivers in school settings. So as we know, there's a high burden of mental health conditions globally among adolescents, and this is even more particularly in adolescents living in low and middle income countries. And as Chesney already mentioned, that we have limited evidence of the prevalence of anxiety and depression among these young adolescents. So to address this gap, phase 1 of my research focused on a tablet-based survey, which was conducted in the Western Cape among 621 adolescents, where the findings of the depression and anxiety symptoms among adolescents highlighted that 33% of these young adolescents who are 10 to 14 years experience symptoms of depression, while 21% of these adolescents experience symptoms of anxiety, as you can see highlighted on the pie chart on the screen. And if you are interested in learning more about this paper, please scan the QR code to read our article. And basically, from these findings, this finding, it highlights that there's a need for evidence-based mental health prevention and promotion interventions for this young age group. And as we know that most existing mental health promotion and prevention interventions have mainly been developed in high-income countries, and very few have been tested in low-middle income countries, including South Africa. So therefore, it's not surprising that adolescents in our context have limited evidence-based mental health promotion and prevention interventions, and particularly with the focus of my intervention, as Chisna already mentioned, interventions that have been adapted for a particular context, and including caregiver component, which is what my intervention has included. So you may be wondering what the EASE intervention is all about. So EASE stands for Early Adolescent Skills for Emotions, and it is a WHO, World Health Organization intervention, which focuses on young adolescents who are 10 to 14 years, experiencing symptoms of depression and anxiety, and their caregivers. So if you look at the table on the screen, it basically breaks down the structure of the sessions. So for the adolescents, we have 7 sessions which focus on teaching them emotional regulation skills. So this includes just being able to identify their feelings, and also, breathing, so being able to calm their bodies. And then we also focus on teaching them behavioral activation skills, as well as problem-solving skills. And then for the caregivers, we have 3 sessions which focus on teaching them mental health psychoeducational skills, as well as positive parenting skills and caregiver self-care and stress management. And both for the adolescents and caregivers, these sessions are group-based, and each session is 1 hour, 30 minutes. So the EASE intervention has been or has undergone clinical trial testing in 4 low and middle income countries. And even though this is the case, it's also important for me to mention that this is one of the very few interventions that have been specifically developed for use in low and middle income countries. And we still had to test its feasibility and acceptability within our South African context. So next, I'll take you briefly through our co-adaptation process, quite similar to Chesney's process, which was guided by the human-centered design approach. And we used the ecological validity model to basically review aspects of the intervention, such as the materials and some of the program delivery. And through a series of adaptation workshops, we had 28 adolescents, their caregivers, and 6 mental health experts, which also included WHO consultants. As Chesney has already mentioned, and Claire, we really value the input of the CPMH Youth Development Team throughout this process, which is our advisory board. And after we had a manualized version of the intervention, we pre-pilot tested it with 1 group of adolescents and their caregivers. So naturally, the next step was then, we had this intervention that we had co-adapted. So it was obviously to test its feasibility and acceptability with young adolescents and their caregivers. And this was through using a quasi-experimental pre-post feasibility study design across 4 schools in Cape Town. We recruited 79 adolescents who are 10 to 14 years and their caregivers. And the EASE interventions are group-based sessions, as I mentioned. So for the adolescents, we had a maximum of 12 adolescents in each group. And for the caregivers, we had between 12 to 15 adolescents in each group. And for the adolescents, the sessions took place during school time and after school, depending on the schools that we were working with. And for the caregivers, all sessions took place in the evenings. We trained 6
six trained facilitators, which included registered counselors and social workers. So we had 2 facilitators running each group. So we had a couple primary feasibility outcomes, and this included the recruitment of the adolescents and caregivers in the intervention, the retention of adolescents and caregivers in the intervention, the competencies of our facilitators, as well as loss to follow-up and follow-up assessments. We also had secondary outcomes for our research, which included depression, which was measured using the patient health questionnaire for adolescents and the patient health questionnaire for the adults or for the caregivers. Anxiety, which was measured using the generalized anxiety disorder screen 7, and emotional regulation, which was measured using the DERS. In terms of the acceptability outcomes, these were measured in 2 methods. So first, quantitatively using the child evaluation inventory, and second, through qualitative interviews with 30 adolescents, caregivers, facilitators, and stakeholders. And this was to explore the perceptions of the acceptability of the intervention delivery and the program in general. So next, I'll take you through the feasibility outcomes, as you can see highlighted or reported in this concert diagram. So we screened 150 adolescents, and 79 adolescents were enrolled and completed the baseline assessment, and 33 of the caregivers. So they went through the full EASE program, which was in person. And then, as you can see, we had quite high intervention retention, with 79% of the caregivers having completed all 3 of the caregiver sessions, and 85% of the adolescents who haven't completed all 7 of the EASE adolescent sessions. And looking at the post-intervention assessment, we had low attrition at the 1-week post-intervention lost to follow-up, with 2 caregivers lost to follow-up and only 1 adolescent lost to follow-up. And at the 3-month follow-up, we had lost 4 caregivers and lost 24 adolescents to follow-up. And some of the reasons for loss to follow-up included adolescents and their caregivers moving locations, changing schools, being absent from school. And I wanted to mention that most of these our follow-up assessments happened after exam time. So most adolescents generally just don't go to school after exam. So we couldn't follow them up within our 30-day window period, hence why we had a higher loss to follow-up in our 3-month mark. Next, I'll move on to our facilitator recruitment and competency. So as Chesney mentioned, we did have a very comprehensive facilitator training, and this includes a series of presentations, brainstorming, group discussions, and lots of role plays. And we also measured the facilitator's competency. So to ensure fidelity, all of our sessions were audio recorded and rated using the therapeutic attributes and competencies for team groups in South Africa. In short, TACT SA, and this measures the facilitator's competencies with regards to their qualities, their group facilitation skills, as well as communication skills. We also had quite a comprehensive supervision method where each of the pair facilitators first did a pre-session role play and then received feedback from 2 experienced raters as well as peer raters. And then we also focus on obviously the EASE content-based materials such as the intervention content, and we also did other ad hoc skills training which came up, for example, such as how to manage group dynamics and as the intervention was in full swing. And we also had weekly in-person supervision and daily debriefings which took place on WhatsApp. So moving on to the facilitator competency and facilitators. That's one of our facilitators, Bulelani, here in the room with us. So the findings from the TACT SA competency score for the adolescent facilitators was 88% compared to the TACT SA competency score for the caregivers, which is 90%. And in terms of the EASE intervention fidelity mean score, we had 93% for the adolescent facilitators and 95% for the caregiver facilitators. Next, moving on to the feasibility study results for the clinical outcomes. As you can see highlighted on the screen, The table highlights the t-test findings for depression, anxiety, and emotional regulation scores from baseline to the 3-month follow-up. Looking at depression, we see that from baseline to 3-month follow-up, there was a mean difference of 1.12. And looking at anxiety, there was a mean difference of 3.74. And in terms of emotional regulation, we see that from baseline to 3-month follow-up, there was a mean difference of 3.84. In simple terms, this basically means that the ease intervention had a statistically significant impact on the depression, anxiety, and emotional regulation scores of our participants. Next, the graph shows the results of the child in inventory evaluation. As Chesney mentioned, we only took scores of those who had scored 4 and above on this scale, and this basically highlights that most of the participants found the ease intervention to be acceptable. As you can see, in terms of perception of the facilitators was 79%, and perception of this application of the skills learned, which I think is very important, was, if you round it off, 78%. So generally highly acceptable across the board. And these are some of the highlights or some of the quotes that we've highlighted from our qualitative interviews from the participants, both the adolescents and the caregivers, in terms of just the experience and the benefits of the ease intervention. So I will read two. I will read Teen 2, who said, "I learned about how to calm myself down, how to control your anger. So I was using the skills when I was alone, when there's someone that makes me angry. Then I go home and get into my room and take out my ease book and read and follow all the steps that Ms. Zolega was telling us to do." Who's also one of our previous ease facilitators in the room. And parent 1 said, there are a few things like how to treat my child, not to scream on him or give him just a hiding or whatsoever, just to talk to him and say what was wrong. So this is some of the feedback that we've received from our qualitative interviews. So to conclude, what we can conclude from this research is that contextual adaptation work is very important. That includes adolescents and caregivers. And the initial findings of this research show us that the ease essay intervention is acceptable and feasible to deliver in South Africa. However, the next steps would be, as she's already mentioned, we are already implementing it with our partner organization, but in terms of more rigorous research would then to kind of evaluate our interventions in a randomized controlled trial. And finally, I'd like to thank the Struengmann initiative, firstly for funding this research, Prof. Sorsdahl and Claire van der Westhuizen, all the facilitators and everyone who participated in this research.
Thank you, Miriam, and thanks to everyone who presented in capacity building and Miriam Richard, your project. It was lovely to hear. So I'm going to hand over to Suzanne, who will also introduce herself as she starts. Thanks for being here, Suzanne.
Good morning, lovely to see you all. My name is Suzanne Niemann. I'm a registered counsellor, worked for Community Keepers before. You've maybe seen their name on the slides. And currently busy with my PhD in psychology through Stellenbosch University. So in their absence, a shout out to Professor Bronwyn Coetzee, my supervisor, and then co-supervisor Dr. Maria Loads from the University of Bath. Seems when you come sit here, you lose the ability to speak. Okay. And obviously, huge thank you to the Harry Crossley Foundation for funding, and Community Keepers, the research partner from the very start. So I don't need to share this with this room of people. We know that many children and young people in our country suffer from mental health problems. We desperately need more early intervention work, and parents or caregivers play a vital role in supporting their children's mental health. From research conducted in high-income countries, we know that parents or caregivers can be equipped to support their children by working with them and developing specifically CBT-based skills. But like we've already heard today, we cannot just copy and paste an intervention developed in the UK to our context. Okay, so I wanted to find out what local and international experts think about the idea of developing and implementing a CBT-based or not mental health intervention for children in primary school, but to be facilitated to them by their primary caregiver. So should we even do this? And then also wanting to find out from caregivers, parents themselves, what do they think about this idea? So I'll be speaking about some of the findings from my PhD that's still ongoing. So I conducted individual interviews with 30 participants. The exception of one interview where a grandma and grandpa from different sides of the family came for an interview together. All interviews were conducted individually. As you can see, a blend of in-person, online, or over the phone, conducted in English or Afrikaans, audio recorded, transcribed, that whole process. So who were my 11 expert participants? 7 from South Africa, 4 from the UK, and six of the South African experts were from community keepers based at the 2 schools where I'm doing this work. So the experts included clinical psychologists, lecturers, researchers, a former primary school teacher, a digital mental health care consultant, registered counselor, social worker. So a nice range of individuals. Who were my parent participants? Mostly they were the biological mothers, but there were also fathers, grandmas, grandpas, and even non-family caregivers. Most of the caregiver participants, the highest level of education was some high school education. And something that stands out from this slide when we think about the caregivers is the little time that they spend on average per day with their child, 2 to 3 hours. And that's including the chaos before going to school. That's including dinner time, bath time, homework, supper. So if we as researchers and service providers are thinking of working with caregivers, we really have very, very little time available with them. So themes that I generated from the data speak to: should we be doing this in the first place? Is there value in developing a mental health intervention for children, but to be facilitated to them by their parents? Should we do it? What are some of the barriers that might make it difficult for caregivers to work with mental health care service providers? If we decide to do this, what should the intervention focus on? And then what do the caregivers need from us as researchers and service providers? So, like I told the participants, this is the idea that I'm putting on the table. Is it even worth doing? Yes, resounding yes. Why? It could be a low intensity intervention. So you could meet with a caregiver less times than with a child. It's a way to make services available to more families. Caregivers tend to have more than one kid. The influential role that caregivers have in their children's life. We also know that caregiver behaviors can contribute to children's mental health problems. So there's really a wonderful role that they can play. Parents are the experts. They spend the time with their children. They know their children the best. It's to also empower, support parents. And then if, let's say, community keeper staff and caregivers can both support the kid, then the better outcomes, hopefully. It could be that parents are more motivated than children, because as a parent, as a caregiver, I want the best for my kid. I want better for my kid than maybe I had. they maybe also remember more about what you actually talked about in the session. And then there could be a theoretical contribution here saying, look here, down here in South Africa, we're also working with parents. Some of the physical barriers, that first bullet ended up on the wrong slide, but how can some of the physical barriers be addressed? How do we reach parents? Some of them do come to school evenings or school concerts. Invite them when they are already at school. Don't ask them to come in only for this. We as the service providers are going to have to be flexible in how we meet with parents. It's going to have to be a mix of in-person, online, over the phone. Some would want to meet in groups, some not. I had a grandpa tell me, look, I'm retired, I've got a lot of time. And I know there are a lot of other grandfathers and grandmothers out here. Why can't we come like every Tuesday morning and meet? So for the grandparents, it might work to meet in person as a group, but for the working parents, online might be the only choice. Then when it comes to meeting in person specifically, it might mean that as community keeper staff, we need to go to their place of work. I conducted interviews with parents during their lunch break on the farm in between somewhere. That's the time that they had available. Maybe negotiate with employers, maybe farmers, when in the year is the less busy times for us to maybe work with our caregivers who are farm workers, for example. Might be a case of caregivers needing transportation to come to the school. Maybe it's a case of over weekends. And then in all of this, the importance of safety for the caregivers and safety for the service providers. And then lastly, for written content to be simple, especially keeping in mind many of our parents only have some level of high school education. How could some of the psychosocial barriers be addressed? Bullet one from the previous slide, let's invite all parents. So for it to be less stigmatizing, this is an intervention open to all. There's nothing wrong with you or your child. It's skills that we can all learn from. And then for parents, caregivers to see community staff, community keeper staff, not only in the community keeper's office, but also at the school concert and at the sporting event on a Saturday. So you are not only the mental health person, you are actually also a regular human being. Then explain what this intervention is and what it isn't. So it isn't treatment for a child with a mental health diagnosis. It's not for parents who are doing something wrong. So explain the boundaries. The human connection, like you, the service provider, is what can break down the nerves, the anxiety, the stigma. To really respect and treat the parent as the expert, they spend way more time with the kid than you will ever. To be non-judgmental, to listen to their concerns, to listen to their worries, and to also focus on the positives. We're in mental health, so oftentimes it's symptoms or problems, but let's also speak about the positives in the lives of kids and their parents. Okay, so what should this intervention focus on? A big question that I had was, do we need to focus on the mental health of the caregivers or not? And mixed views amongst the participants. So some participants said, yes, we need to focus on the mental health of parents, because how can a caregiver support a child if a caregiver themselves isn't okay? And the metaphor of the caregiver being the vehicle transporting this precious cargo that is the kid. And then other parents and experts said, no, you are advertising this as something for all parents to help their children. And now when you see me, you focus on me. So then I'm going to interpret that as you telling me I did nothing wrong, but now you start with me. So feelings of shame, guilt. also researchers with experience working with parents saying, look, we actually don't need to focus on the mental health of the caregiver to have good outcomes in the child. Rather, encourage the caregiver to also try out these skills, these strategies for themselves. They might be more open to it if you don't put the spotlight on them. And then afterwards, if needs be, you can then refer the caregiver for extra support, but not to start off by putting the spotlight on the caregiver. More of what it should focus on, one package for all. So it's going to be very daunting for registered counsellors or social workers or social auxiliary workers or mental health first aiders to do a needs assessment of every individual family. So we're going to do all the strategies, all the activities with all caregivers, and I'm starting to think of it like veggies. We all know we need to eat vegetables. So you try them all out and then you only eat the ones that you like and you don't eat the rest. So sort of a thing of, here's all the veggies. Try them all out, and whatever works best for you and your family and your child, go ahead with that. To tell the parents change takes time. Teens don't always want to speak. They don't always want to speak right away. Don't lose hope. Don't lose patience. Maybe 2 months from now, they will come back to you. So be patient with them. Then the focus needs to be on the parent-child relationship. We can have all the most cool activities in the world, but if there's no relationship, the caregiver is not going to want to do this with the kid, and the kid is not going to want to do this with the parent. So strategies, okay, and then also to start with, what are you as the caregiver already doing? Oftentimes caregivers are already doing more and they may be not aware of it. So start by what they're already doing and then add new suggestions. Strategies to get kids talking. If you have that 15 minutes that you're having a meal together, here are some questions that you can ask your kid. CBT-based activities to focus on, self-esteem, identity, then also feelings, how to make myself feel better, how can I challenge change my unhelpful thoughts, and then lastly also problem solving, focusing on what's in my control, what's out of my control, and problem solving stuff that's actually in my control. And what parents need from service providers. So there were no consensus on number of sessions that this intervention should be, no consensus on number of sessions of training needed. We are going to have to be flexible in how we meet with caregivers. The content will have to be visual, less words, whether it be worksheets or online stuff, visual, less words, and then fidelity to content across the format. So whether it's a hard copy form, a TikTok video, so many of the caregivers are on TikTok. I'm still a little bit afraid of it. But the content needs to be the same. And then what do they need? They need us. They need the service providers. They need to know there's someone on the other end of the telephone or the WhatsApp. Okay, so given all of the above, didn't expect this, the beauty of research. It's going to be a series of single session interventions so that if a caregiver can only come to one, they can already go use something. It's not that they have to do the whole program to be able to implement stuff. Flexibility in delivery, fidelity to content, and then CBT-based, evidence-based as far as possible. Format of each single session will be, didn't speak to this in today's talk, but safety check. Is the child or the parent in immediate harm from self or others? Then the parent-child relationship, some brainstorming there. Then the basic CBT triangle, how thoughts, feelings, and behavior all influence one another. Then the topic of the day's session. Then what are you already doing in terms of the topic of today's session? Then here's some new ideas, and then refer if needed. And then the 5 sessions that I have in mind is we can get to know one another better. So a whole session focused on parent-child relationship. Then we can be proud of who we are and what we can do, identity, self-esteem, finding your strengths. And then we can do something to feel better. We can change our unhelpful thoughts and we can choose what to do. Thank you.
Thanks so much, Suzanne. It's wonderful to hear about all the amazing work, and that as parents, there are resources out there. I think we're all in the business of providing mental health nutrition, clearly, with a range of veggies. That's wonderful. Now I'm going to hand over to Emily. Hi everyone. So I'm going to talk about the ALIFE project, which stands for Improving Adolescent Mental Health by Tackling the Impact of Poverty. It's a project that's funded by the Wellcome Trust. And I'm just talking on behalf of the South African team. They're all very busy and on the field at the moment. There are a few faces here. But yeah, so just to let you know, this is really the work of the South African team. And I'm the scientific coordinator, so I sort of coordinated 3 sites, including South Africa. So I'll give you a brief introduction of the ALIFE project and then specifically the progress in South Africa, and then Zoleke will talk to the challenges and successes of the project so far, and then just to give you a brief overview of the next steps. So the ALIFE project, the aim of the ALIFE project is to develop and pilot test an intervention that combines poverty reduction with strengthening self-regulation to prevent depression and anxiety among adolescents living in urban poverty in Colombia, Nepal, and South Africa. So these are the 3 sites. So the first objective of the project was to develop a theoretical model to understand the underlying mechanisms linking poverty, self-regulation, and depression and anxiety among adolescents in low and middle-income countries. And so this realist synthesis was the first part of addressing this objective, and this was really to understand sort of the identifying literature to understand what works for whom, under what circumstances, how and why. And then the second part was to conduct sort of qualitative formative research using the narrative approach, so interviews using the narrative approach, to explore the type of self-regulation skills that adolescents used in context of poverty or other challenging situations. And then these findings not only informed this theoretical model, but also informed the content of the intervention we wanted to develop. So that brings me to the second objective, which was to develop a selective prevention intervention for adolescents living in poverty and so at risk of developing anxiety or depression. And based on the formative findings and based on literature, the idea was to identify key ingredients to incorporate in that intervention, basically breaking down sort of complex interventions into smaller parts that were important but not necessarily dependent on one another. We tried to use a human-centered design process, so sort of an iterative process when we developed that intervention. So it was basically just involving stakeholders and adolescents in the process and continually getting their feedback on the intervention development and the content. And part of this process was to refine the intervention through N-of-1 studies to assess the feasibility and relevance of the intervention, but I'll talk about this a bit more later. So the LIME intervention is now developed. So I thought I'd give you a brief overview of the intervention. So there are 2 parts. So the economic part, also the idea is that there would be 20 sessions delivered weekly to adolescents and 6 monthly sessions delivered to their caregivers in groups over a period of 4 to 6 months across the 3 sites. And so the economic part included a cash transfer to the adolescents and the parents to try and relieve sort of budget constraints. And the idea is that by relieving those constraints, they're in a better position to then assimilate new information and knowledge and building human capital. And this human capital will be built using providing information on education, bargaining, and financial education to both adolescents and parents. And then the self-regulation part was about building emotional and cognitive regulation skills to try and promote behavior regulation.
And we really wanted to make sure that the intervention provided a safe and trusting environment, and we thought we would do that through a physical and social activity that they could master. And so in South Africa, we chose surfing. So that's being done through the Waves for Change program. And in Colombia, they're doing skateboarding. And then in Nepal, they're doing a martial arts based activity. And not only this, but we also wanted to make sure to promote co-regulation, so have support adolescents to use the new skills they've learned by sort of getting support from their family and their caregiver. So the parent aspect of the intervention is focusing on reducing stress and improving parenting practices as well. Oops, sorry, I went too fast. So the third objective was to select, adapt, and validate key instruments for the pilot study. So the idea was to identify instruments and validate instruments that would help identify eligible adolescents for the intervention, instruments relating to the outcomes of the intervention, and mediators, so hypothesized mechanism of action such as education and self-regulation and education, for example, and also instruments relating to the implementation of the intervention, because it's a feasibility study in the end. And we did this through a transcultural translation and adaptation process, which involved a series of focus group discussions, cognitive testing interviews, and pilot assessments for each of those instruments, and many. And that also involved sort of a cross-sectional survey that involved 500 participants and their caregivers in each site, where we would sort of administer those self-report instruments and use psychological apps to a bigger sample to try and assess associations among the different instruments to see how they actually work together, and if they're actually feasible to implement for the pilot trial. And then finally, the fourth objective was to conduct the pilot trial to test the feasibility and acceptability of the intervention, the cost of the intervention, and also trial procedures and the measures themselves. And so, of course, we're interested in the actual combined, so the alive intervention, where we're combining both economic and self-regulation components. But we also wanted to know whether that combined intervention is more effective than each component alone. So in the pilot trial, we have 4 arms, the self-regulation arm, the economic arm, the combined arm, and then the control arm, which is care as usual. And then throughout it's not an objective as such, but throughout our research activities, we engage with young people and policymakers and academics to maximize the relevance and the suitability of the activities, really to make sure that the intervention is acceptable to adolescents and making sure that we give adolescents a voice, essentially. And we did that through the youth, the YDT, so the youth development team at the center. So we were able to, I don't want to say use, but we were able to ask some of those adolescents from the youth development team so their feedback on the intervention throughout the process. So finally, moving on to the progress in South Africa specifically. So the South African team have done a fantastic job of keeping up with everything in the last 2-3 years, because we've been very busy. So they conducted all the formative work interviews with adolescents from January to March 2023, so last year. And we sort of tried to identify the self-regulation skills that adolescents already had and the ones that they were lacking to try and feed into the intervention development. I believe all the transcripts have been, all the interviews have been transcribed and analyzed, and they're busy writing the paper now. And so in South Africa, there was a decision that the interventions for both adolescents and for caregivers would be in English, but that some aspects would be translated to Xhosa or Afrikaans, especially the difficult concepts. And then the coaches would be able to be bilingual or trilingual, just to be able to help out, especially caregivers, in case they don't understand specific difficult concepts. But there were definitely adaptations needed, especially the economic aspect, where they needed a bit more clarity on certain difficult concepts, and also to make it a bit more fun. The self-regulation aspect, given that surfing was already quite enjoyable, but then the economic aspect was quite didactic, and they wanted to have a bit more interaction in the intervention. So we conducted a workshop with experts to refine our theory of change map, just to make sure that the delivery of the intervention, the content of the intervention was adequate for our context. And then, like I mentioned, we consulted with the adolescents of the YDT throughout the process as well to help adapt the intervention. And as mentioned, so the N of 1 study was also used to finalize and sort of make any final changes to the intervention, or the 3 interventions. And so that consisted of providing 4 weekly sessions with adolescents and 1 session with caregivers. So it's basically a very condensed version of the intervention. Just we kind of selected 4 key sessions we thought would be useful to test. So it's like a pilot of a pilot. And so we had 6 adolescents per intervention group. And so we assessed what they thought of the session after as a short interview at the end of each session, and also checked for the depression and anxiety scores weekly before, during, and after the intervention to kind of see if there are any changes, whether it be good or bad, just to see if the intervention had an impact on the symptoms. And then we also tested things like fidelity checklists and a platform called TeamPact to check for attendance. So just to see if those little platforms that we would use for the pilot were actually user-friendly and worked well. And then the adaptation of the self-report instruments took about a year, because it was a thorough process of, like I mentioned, so the focus group discussions, cognitive interviews, and pilot assessments with like 60 participants. So all the instruments and the neuropsychological tasks were in English for the adolescents, but they were in English, Afrikaans, and Xhosa for the caregivers. So all this needed to be done again in Xhosa and Afrikaans for the caregivers. So it was a lot of work. And as I mentioned, there was also a validation part with a bigger sample, just to assess associations and how the instruments were delivered among a bigger sample. And that also included the validation of the PHQ-A and the GAD-7 to assess depressive symptoms and anxiety symptoms to identify a cutoff. I think about 150 adolescents did actually do the diagnostic interview, and then there might be more participants recruited in the next couple of weeks or months to supplement that. And then finally, the pilot RCT is currently underway. So the baseline assessments, recruitment and baseline assessments happened in April and May this year, and the intervention is nearly completed, or the interventions nearly completed. And they are busy starting with the follow-up assessments with the caregivers, and will do that. Okay, we'll continue with the adolescents in the next couple of weeks. I'm going to let Zuleka give an overview of the challenges and successes this past couple of years.
Good morning, everyone. I'm one of the research assistants. I will talk about the key challenges. First of all, I will talk about the red flags. Caregivers and adolescents those who screen high for depression and anxiety. We do have a psychosocial support, which means registered counselors, but they are the team of Alive, not outside people. And also, I will talk about the need for psychosocial support for the adolescents. When our registered counselor, they are due to their 3 sessions, they will refer them to the community services like social development and other departments where they can get help. And also, we have ongoing follow-ups while they are doing those sessions with outside departments, whereby the registered counselor, they will check the progress from the teenagers and their parents. I will talk now about the challenges. The communication, which sometimes is becoming difficult because of high crime, where the teachers, they are we select one teacher as our contact person. Several times we find out the teachers, they are being robbed the phones, and also the kids and the caregivers. So somewhere, somehow, it's difficult for us to contact them. Then we have to visit the schools in person, whereby they will give us sometimes the addresses, but the teachers, they always have the second option that we can get hold of them. And also high crime also, whereby the landlines for schools, they are being cut due to the crime in our communities. So we are unable to contact the principals, for example, if we need something for our participant. And also what we usually do, we have the appreciation whereby we give gifts and also the treats and also the certificate after our interventions. And and also we do the feedback. Our feedback, it works like the progress. We check the progress through our survey and also our qualitative interviews. And the next one, I will talk about the successes of the mini study, November 2023, whereby the parents, they receive 2,000 for cash transfer, and also the kids, they receive their money. One of the caregivers, she used the cash transfer to buy the seeds and also the fertilizer to start the garden. As time goes on, I just exchange the number, the work number. During April, she sent the photos on my right-hand side, where she started to buy the seeds and also the fertilizer, and she started to plant here. I think it was June or July. She sent the production over the pictures that now she have the vegetable garden. And also she bought some beauty suppliers for her daughter to do hair, nails, makeups. And also one of the parents, she bought some devices for the adolescent so that the adolescent can do the homework and also the extra activities from school due to the cash transfer that they receive from my life. That's all on my side.
Thanks, Annika. And hopefully we'll get more success stories after the pilot. Just to let you know, the intervention, like I said, is nearly complete, so should be done in the next couple of weeks. And the next year will be focused on conducting interviews with all stakeholders to get information on feasibility and acceptability of the intervention, and complete the follow-up assessments and publish all the findings. So that's going to be a lot of work. And again, just wanted to thank the South African team for all their hard work. Thank you.
Thanks so much, Emily and Zaleka. Yeah, as Emily said, it's been busy. There's no end to the jokes. Life has been lively. It's a dedicated, enthusiastic team, like across all our projects. And you see the veggies pushed up again. All right, so now I'm going to hand over to our colleagues, Liesel and Tyler from the Perinatal Mental Health Project.
Thanks, Gillian. So my name is Lisa Lamanis. I'm a registered counsellor and I'm also the clinical services coordinator with the Perinatal Mental Health Project. And I'm also currently in my second year of my master's in infant mental health with Stellenbosch University. Just apologies quickly from the rest of our team. So Simone Honigman, who's the director of the PMHP, she's not feeling well, so she is joining remotely. And then Thanya and Keisha were unable to attend because they are on a training course today and tomorrow. So apologies from them. So for my presentation, I'll just be giving you an overview of the maternal support service, which is based at Hanover Park Maternity Unit. And this is really just some of the work that we are doing. And so a snapshot of the service for 2024 and some of the changes that have occurred in the service during this time as well. So this is a flow diagram of our maternal support service, which is a comprehensive and collaborative stepped care model, which we have managed to successfully embed and integrate into antenatal and postnatal care at Hanover Park Maternity Unit. Okay. So I just want to draw your attention to the very first block, which says PPP. So promotion, prevention, and prep for the service. So before there's any screening that is happening, there is this PPP that happens. And what this looks like is a waiting room talk. And so this is with clients who are coming for their first appointments, follow-up appointments, ultrasounds. It could be that their partners are with them, aunties, neighbor, granny. So we work this way. The waiting room is full. It's a full waiting area, and there's different clients from families to friends as well. And so what we're wanting to do with this waiting room talk is not only to prepare clients, so your new bookings for the service and the screening, but we're also wanting to normalize the conversation around mental health during pregnancy and postnatally, because we know that particularly in Black and coloured communities, this is a very difficult conversation to have. And so part of the PPP and this waiting room talk is to be like, let's talk about this and what you are experiencing during your pregnancy and postnatally as well, that this is actually normal. Because we try to make, and this is normally both Tyler and I will do the PPP, and we try to make it as informal and interactive as possible. And so we'll ask clients, what do you think of when you hear mental health? And so you'll hear somebody shouting depression, anxiety, but then you'll also hear somebody saying she's crazy or she's mad or says malman. And so we're really trying to change the narrative with this PPP and with the waiting room talk, so that it's not he says mal, but rather what she's experiencing is actually quite common, and this is a mental health problem. Okay, and then I'm just going to run through this. So then there's universal screening that happens, and this is done by the midwives at the maternity unit. And they are using a brief 3-item tool, screening tool, the maternal distress tool, and this was developed and validated by the PMHP. And so we're looking at symptoms of depression, anxiety, and suicidality. So all bookings are then screened by the midwives, those who have a positive MDT score, and so they've scored 2 out of 3, or they've answered yes to the suicidality, they are immediately referred to the PMHP. But besides those who score positive, we also have targeted populations. And so these include teenagers, clients who are newly diagnosed, those who have a known HIV status, previous clients of the service, GBV, a mental health, psychiatric history, but also clients who staff are particularly concerned about. Those clients will also be sent through to the PMHP. Once they get to the PMHP, they are then onboarded by the health promotions officer, and they are then offered an EAT session with Tyler. And so your EAT session it's engage, assess, and triage. And what happens during the EAT session, Tyler is repeating the 3-item screening tool. She's also doing a a risk assessment, and then having a brief conversation with clients to assess the level of care that clients need. And so we have 3 different types of counseling referral. So we have a low intensity intervention, which is also known as a minor intervention. And so this is an extension of the EAT session. And so this could include psychoeducation, it could include birth preparation, and this can take anywhere from an extra 10 to 20 minutes after or into the EAT session. And then we also have moderate intensity intervention. And so those clients are referred to Tyler, and those needing high intensity intervention are then referred to myself. Both Tyler and I, once clients are in the counseling program or the maternal support service, we do a postnatal assessment. So it's a very structured postnatal assessment that we do around 6 to 8 weeks postnatally. And we are currently rethinking and restructuring this postnatal assessment, but Tyler will chat to you a little bit more about that. And then just very quickly, in terms of stats, so from Jan till up to and including September, we had around 1,500 women booking at an Overpark maternity unit. 407 women were screened by the Perinatal Mental Health Project. 350 qualified for counselling. And then of the 350 women, 309 women were referred for medium and high intensity care. So those were clients referred to Tyler and I. And then 73 women required a low intensity care, so a minor intervention that I just spoke to you about. Okay. And from January up to and including September, between Tyler and I, we've seen 231 new clients with an average of 3 to 4 sessions per client. Okay. The PMHP also had an opportunity to partner and collaborate with the Western Cape Department of Health and Wellness to conduct training with staff at 8 maternity units in the Cape Metro district. And the training covered practical techniques to conduct the mental health screening of the 3-item screening tool. But the training was also more than just the 3-item screening tool. It also, we had a component of maternal mental health embedded in the training. We also used different resources, including a film that was developed by the PMHP. And what was interesting to note from the training that we had at the different MOUs, a lot of staff spoke about the challenges and the barriers to facilitating this this brief 3-item screening tool. So an example, a lot of staff spoke about, we don't have time to do this. We have 20 patients waiting outside for us. You have other staff who are in and out of your room, making it extremely difficult to ask questions or ask clients questions about depression, anxiety, and suicidality. Some staff also mentioned not feeling that they had the skills to contain clients. And they often spoke about opening up a can of worms. And so what if I'm asking about depression and anxiety and this person unpacks and I can't contain them? What do I then do with this client? In response to the time question and not having enough time, my response to that is always, if you can greet your client, introduce yourself, and refer to your client or refer to the client by their name, then you've already done a lot. And doing those 3 things doesn't take a lot of time. Okay. And then, as mentioned, I am currently in the 2nd year of my my master's in infant mental health, and in doing this program, it has really afforded the PMHP an opportunity to think about the work that we are doing with mothers, because the focus has always been the mother, and but through the master's program, we've been thinking extensively about expanding the service to include the baby in the counseling session. And so the work that we are doing is more around the mother and the infant. Okay, and working with that diet. And that has been extremely exciting and interesting. And this has also meant increased liaison with stakeholders. There's a photo of a workshop that we had with Dr. Astrid Berg, and Simon's also liaised with a lot of experts just to give some input into the increased infant work that we have been doing. I just want to make sure, am I okay with time? Tyler? We're sharing now. Sorry? So, oh, okay. So just to about the work with infants, we're really trying to get mommies or our caregivers to think about the infant as its own person with its own mind and its own thoughts and its own feelings. So a lot of mentalization. So mommy, what do you think when baby is doing this or doing that, or how do you understand this? Or how do you understand that? And some clients are able to mentalize and others aren't. And that's where Tyler and I will come in, and there's a lot of modeling that happens. And then drawing attention, the mother's attention to, like when the baby's smiling or making eye contact, the woman like, oh, like, look, mommy, like, look how she smiles when she hears your voice. Or if the baby's distressed, trying to ask the mommy, how do you understand that? So very exciting. But I'm going to stop now because I can go on and on about this. I'm going to hand over to Tyler now. Thank you.
Good morning. I think it's still morning. Good morning, everybody. I'm just going to chat very briefly around what we are thinking about as a project around our monitoring and evaluation components of the service that's in Anova Park. To the left is what our current REDCap database looks like. It's very scant, so we've really tried to look at how to strengthen and almost have a more comprehensive monitoring and evaluation process while still holding space for the fact that it's a very practical and living organism that the service runs. So we didn't want to impact the service with overly complicated monitoring and evaluation process, but the monitoring and evaluation is important. So what we're looking at including is more detail around client management and case management. What we are also trying to look at is different screening measures to assess change over time, because the 3-item questionnaire is not sufficient enough to measure change over time. So we're looking at the GAD-7 for baseline, postnatal, and then an endline assessment. What we have also field tested is an Aboriginal version of the EPDS, which is the Kimberley Mum's mood scale. The Aboriginal version sort of speaks to our context a little bit more, and that seems to be working already. What we are also looking at, and Liesl touched on it very briefly, is the postnatal assessment process becoming a little bit more in depth with regards to infant outcomes, and for maternal sensitivity and responsiveness to be proxies for attachment, because of the 6 to 8 week window is quite young for the infant. But then we are also looking at what the endline assessment can cover in terms of problem resolution. We, in the past, have struggled with the postnatal assessments with clients falling out of the system after antenatal care. So what we've looked at doing and including is session by session degrees of problem resolution assessment to look at any time point when they've come back for a follow-up session, has there been any resolution of presenting problems, and has there been any additional intervening life events that may be impacting the client. So we're really looking at the client's experience in a lot more depth. And I'm very briefly going to chat about a current research project that we're busy with, which is the Secret History mobile application feasibility study, which was a quasi-experimental mixed method study, and it was looking at adapting the Secret History training manuals into a choose your own adventure mobile application to look at gamifying learning and training, mainly to address obstetric violence and facilitating respectful maternity care. The application was on the ComCare platform, and it was facilitated over a period of a couple of months, and at various time points data was collected as well. The app itself is looking at the health workers' experience with very common stories that they would encounter in clients and how to navigate engaging with clients that might be perceived as difficult or difficult situations. And there is a user interface where the health worker is able to have a response where you input your feelings and needs, but also empathically think about what the client in the situation might be feeling and might be needing as well. There's some perceptions that was mixed. Some people really enjoyed the app. Some people thought that the story wasn't nuanced enough and was too good or too bad. So what we're working now on is sort of developing a more comprehensive story, wider stories as well. The resource section that's connected to the app seems to be something that's quite enjoyable by participants. So we're looking at keeping that in as well. And we have noticed the behavior and attitudinal changes. What's happening at the moment, the ComCare platform in terms of feasibility wasn't the most ideal for participants. So at the moment, the app is being reconfigured into being on WhatsApp. So that is what's going to happen next. It's going to be facilitated via WhatsApp, and then we're going to see whether the shifts in the stories and the nuances in the stories introduce different kind of insights for us to explore.
Thank you.